research awards, including the American Academy of Dermatology Young Investigator Award and the NIH Director's Early Independence Award. I was really excited when Dr. Demehri agreed to join us today and look forward to hearing his thoughts on skin cancer prevention and immunology. Thank you for being here, Dr. Demehri.
Absolutely. Thank you for the invitation. And can you hear me and can you see the slides?
Yep,
yes,
they're coming
perfect.
through. Great.
Thank you. So as was mentioned, I'll be basically talking a little bit in realms of research and understanding of therapeutics as it relates to non-melanoma skin cancers. And before I do that, I do want to spend at least a couple of minutes explaining when we talk about cancer prevention and use of the immune system, what we are really talking about. And this diagram, and before I go into that, I should definitely mention that I've been co-inventors on patents relating to topical immunotherapies for cancer prevention and therapy. So as I mentioned, what we are really talking about with cancer development is really depicted here in a very textbook version of the event, which is progression of a young and healthy organ like in skin over time, exposures to various environmental carcinogens and oncogenic viruses and so forth, leading to development of an aged organ, which is still perfectly functional and architecturally intact, like old skin. However, as we all know, we call those, for example, sun-damaged skin or old skin. They're more prone to development of cancer within them as we age. And similarly to that organ, the immune response and immune system within that organ also undergoes evolution as we age and changes from early young immune responses to a more developed and more experienced immune responses as we age. And many of these alterations in immune responses have been shown to be in response to pathogens and allergens that affect us as humans and as exposures to these environmental, if you will, insults. However, the question remains, which is what is the function and role of these immune responses in this transition from an, if you will, damaged organ to a cancer development within that organ? And clinically speaking about this axis, it's really the question of secondary prevention by the use of immune system. Can we really leverage the immune responses within the organ, namely in this case skin, to block this transition from intact tissue and intact organ to a cancer within that organ? So what we have done in this front has in different aspects of this over the years, but one of the areas that we have been really active in is use of agents. These are immune factors, they're called cytokines, to re-educate the immune response within the organ and try to promote this cancer suppressing benefit of immune system and prevent cancer development. Now, as we talk about non-melanoma skin cancers, this really relates back to the topical use of immunotherapies, novel immunotherapies, to enable this type of skin cancer prevention. This was beautifully explained already there, but when we talk about skin cancers, we mainly talk about keratinocyte carcinomas or squamous cell cancer and basal cell cancers. But also we do think about melanoma and other skin cancers as well. And because all of these skin cancer types could be amendable to a topical immunotherapy for their prevention of development and recurrence. Today I'll be just talking about the squamous cell carcinomas and the work we have done to hopefully showcase how one could really use the immune system in this front. And before I get to that, we would say that in the field of squamous cell cancer, we do have modalities that are aimed for prevention of the cancer. And these are mostly developed to target precancers to squamous cell carcinomas, and those are called actinic keratoses or AKs. The main modality, or one of the main modalities used in the clinic right now, are cryotherapy or freezing of those actinic keratoses when the patient presents to the dermatology, but also use of topical chemotherapy, like that is 5-fluorouracil, which is the most commonly used topical chemotherapy for this for elimination of precancers and hopefully prevention of squamous cell carcinoma. Likewise, we use another cytotoxic, or if you will, chemotherapy-like agent, which is both a chemical application and also light treatment afterwards to enable the killing of these tumor cells within the skin, and also the topical imiquimod, which is an innate immune activating agent that has been around for some time. So what we have done and what we really developed was really came out of fundamental research, looking at skin cancer development in experimental models, and then realizing that there's a novel immunotherapy that stems from this work that could help with the treatment and prevention of squamous cell carcinoma. I would not be talking about the experimental work that we have done, but what really emerged from that experimental and research in models was this understanding that a vitamin D analog, a low calcemic vitamin D analog called calcipotriene, these other names listed here on the slide as well, is a type of chemical that when it's applied topically to the skin can induce an immune factor. And that immune factor or cytokine is a very anti-cancer type of cytokine that could block cancer development in the skin. I should point out that this calcipotriene has been, prior to our discovery, has been used for psoriasis, for treatment of psoriasis in patients, and really enabled this translation of what we have found into the clinic. So based on this discovery, we really wanted to understand, can we use this topical way of inducing immune factors to eliminate precancers and prevent cancer? And to do so, several years ago, we developed a trial looking at this question in immunocompetent patients using this topical agent calcipotriene, which induces the cytokine I mentioned, TSLP, and this induction of immune response then hypothesized to be augmented by the chemotherapy already being used in the clinic, and that's diflurophyll fluorouracil, to enable a potent immune response against these malignant cells within the skin. And we performed this study now several years back, and the results were very promising, demonstrating that this combination of the topical immune factor inducer and chemotherapy can be very effective in eliminating precancerous lesions, but also preventing development of squamous cell carcinoma up to 3 years after the treatment of these patients within this trial. And since that time, it has now been, this topical immunotherapy has been added to the national guidelines for the treatment of multiple precancers, patients who have multiple precancers in their skin. So I would like to emphasize from this type of work that the implementing effective immunotherapy to prevent skin cancer in high-risk patients may be instrumental for our ultimate goal of cancer prevention in patients. And what do we mean by high-risk patients when we talk about skin cancer? Patients who are high risk are patients who are at risk of developing new cancers. And these are, again, non-melanoma skin cancers, multiple of them over time. And there are several categories of these patients that we always see in the clinic, and we really would love to have a better preventive modality for them. And those are patients with history of 4 or more skin cancers in the past. If a person has 4 or more non-melanoma skin cancers in their history, they're almost 75% guaranteed to develop a new one within 2 years. Also, patients with immunosuppression, this was talked about prior, patients with genetic mutations that predisposes them to skin cancer as well. And among these groups that I listed, the really severe and main group that we always see in our clinics are in patients with immunosuppression that develop especially squamous cell carcinomas. And immunosuppressed patients belong to several groups of diseases. Some of them are acquired immunosuppression, and some are inherited in the genome and in the DNA of the patients. The cause of immunosuppression, again, organ transplantation is one of the primary causes of immunosuppression in patients. A disease called chronic lymphocytic leukemia is a very prominent cause of systemic immunosuppression as it relates to skin cancer risk and squamous cell carcinoma risk. Ulcerative colitis and other inflammatory diseases also can increase the risk due to the immunosuppressive medications that these patients receive. And HIV/AIDS, now this problem has been much less nowadays due to better treatments for AIDS and for HIV, but it has been a similar issue in context of skin cancer risk. And I would like to sort of bring up this last slide here as well, that we are now gearing up to enter this realm of bringing immunotherapy to folks who are immunosuppressed and can we see better efficacy and improved efficacy in these patient populations compared to the current treatments they're receiving with mostly chemotherapy-based approaches. And this is really has been a collective effort across several centers in the US, at our hospital, at OHSU and the Washington University in St. Louis, and also University of Arizona, trying to understand and trying to test whether the topical immunotherapy that we have developed could be beneficial for kidney and lung transplant recipients. in order to boost their immune response in their skin and hope that we can at least reduce the rate of skin cancers these folks develop over time. And I should mention that this is obviously sponsored by NIH, the NCI, National Cancer Institute, Division of Cancer Prevention. And that's with that, I just want to close by saying that we do propose that immunotherapy can really revolutionize how we think about cancer prevention, similarly to how it has really proven to be revolutionary in context of cancer therapy. And thank you. That's my last slide. Thank you.